attendees to the session. And
Sorry.
We'll talk more, Dr. Durkin. So
yeah, that sounds great.
Yeah, Dr. Durkin, thank you so much for doing a session for us here at the 2022 Antimicrobial Summit. I think this is the 4th or the 5th year that Illinois has had it. And this is, again, the 3rd or the 4th year that we've had an oral health track. So Dr. Durkin is the co-director of Antimicrobial Stewardship and an associate hospital epidemiologist at Barnes-Jewish Hospital. He's also the medical director of Infectious Prevention and Antibiotic Stewardship at Barnes-Jewish St. Peter's and Progress West Hospitals. Dr. Durkin uses administrative data to identify opportunities to improve antibiotic prescribing in outpatient settings, with a focus on outpatient and community settings. Harnesses survey and qualitative research methods to identify potential solutions based on input from frontline providers, and designs, pilot tests, and disseminates antibiotic stewardship interventions using dissemination and implementation science and informatics technology. He has received grant funding from the CDC, NIH, Missouri Department of Health and Senior Services, and the Foundation for Barnes-Jewish Hospital and the Pew Charitable Trusts. He has evaluated the impact of aerosols in dental environments during COVID-19 pandemic, and that was our side conversation here. He has also worked with infectious diseases, fellows, and faculty to implement quality improvement bundles for persons who inject drugs as part of CDC-funded contract. Dr. Durkin attends on the general infectious diseases and general medicine and bone and joint services teaching fellows, residents, and students. He also sees patients in the general, he also sees patients in the general infectious diseases clinic. He's currently mentoring infectious disease fellows and residents in antimicrobial stewardship, quality research methods, and administrative data. Dr. Durkin particularly enjoys mentoring fellows who are interested in careers in clinical research. Dr. Durkin, I thank you very much for today's session entitled Antimicrobial Stewardship for Dentists. We look forward to your materials.
Thank you so much for the kind introduction, Dr. Van Kagen. So it looks like we've got a good-sized audience with 15 participants here. So feel free to chime in. I'm going to have the question and answers tab open. And Dr. Van Kagen, let me know if there's anything I'm missing while we're chatting too. So overall, we're going to talk about, so I mentioned the disclosures already about grant funding. I also serve as an expert witness for medical malpractice cases. This includes a couple of dental malpractice cases too. And there's a couple of the two law firms that I've worked with recently. So we're going to talk about the need for antimicrobial stewardship in dentistry and kind of the history of antimicrobial stewardship in dentistry, where some of this interest came from. We're going to describe existing stewardship techniques in healthcare outside of dentistry. And then we're going to learn which antimicrobial stewardship techniques have been used in dentistry, predominantly in other countries, and one example in the US as well. So the need for antimicrobial stewardship in dentistry initially was identified based on CDC research. So the CDC used a large administrative data set called IQVIA, which purchases data from health insurance companies to approximate and get a sample of what medications are being prescribed throughout the United States. And the CDC mined this IQVIA database to see what antibiotics are being prescribed and by who. So they evaluated antibiotics in 2011 only in outpatient settings. And you can see in table 2, they kind of looked at all of the prescriber groups. And a lot of them, as you can imagine, make sense, right? Dermatology, pediatrics, ENT, emergency medicine, internal medicine, some physician assistants, but highlighted in red there is dentistry. That was a surprise to the CDC. They saw about 25 million antibiotic prescriptions, which represented about 10% of outpatient antibiotic prescriptions among 122,000 actively prescribing dentists. So these were similar antibiotic prescribing rates to nurse practitioners and OBGYN providers. Should note that there's more dentists than there are a lot of medical specialists, so the antibiotic prescribing rate wasn't as high as in, internal medicine or family practice, but it was still a large percentage of outpatient antibiotic prescribing. So the CDC started becoming very interested in this to try to figure out who's prescribing antibiotics, what antibiotics are being prescribed, and kind of what the rationale was for those antibiotics. So we started looking at this in a separate data set called Express Scripts, which is a pharmacy benefits manager that has about 10% of outpatient antibiotic prescribing. Sorry about that. And we looked at antibiotic prescribing, both looking at days supply, which is a surrogate for how long the antibiotics were being prescribed, or duration. And you can see over here that we saw peaks at 5, 7, and 10 days, which generally we thought was related to antibiotic prescribing to treat dental infections. And then you can see dental specialties here. It might be a little too small on your screens. We saw general dentists were responsible for the bulk of antibiotic prescriptions, but we saw higher antibiotic prescribing rates among oral maxillofacial surgeons, periodontists, endodontists, and oral maxillofacial pathologists. And the antibiotics that were being prescribed were pretty expected overall. We saw amoxicillin. It's kind of the biggest antibiotic, followed by clindamycin and penicillin. But we did see a few unusual antibiotics too that we don't normally think about with dentistry, like azithromycin, cephalexin or Keflex, doxycycline, and augmentin. And we suspect that these are probably related to antibiotic allergies, in particular penicillin allergy. Our manuscript at the time also called out that there probably needs to be more recommendations about how to treat dental infections. So fortunately, the American Dental Association shortly afterwards convened a panel and released guidelines on evaluation and treatment for common dental conditions, including irreversible pulpitis, acute apical abscesses, and things like that too. And the overall recommendations were that antibiotics should really only be used if there's evidence of systemic involvement, which I think Dr. Abt already talked to you all about. And so I think this is very useful and helpful information, and there's a few nice figures in there too. We actually have looked at adherence to the new guidelines. So there's limited amount of data sets to evaluate antibiotic prescribing in dentistry. In particular, one of the things we need to know is whether or not someone has symptoms or not. And historically, most of the dental administrative data sets just use CDT codes, but don't actually evaluate diagnosis codes, which in medicine we call ICD-10 codes. So the data that kind of evaluates this is largely from VA data sets, where dentists would code both using procedure codes, CDT codes, and diagnosis codes, ICD-10 codes. And we evaluated the adherence to the new American Dental Association guidelines in VA data. And actually, most dentists were doing pretty well. Most treatments for irreversible pulpitis and apical periodontitis were concordant with the new guidelines. One thing that we did note was that antibiotic prescription durations were longer than what was generally recommended. In the guidelines, they said 3 to 7 days, and we saw a lot of prescriptions that were beyond 7 days overall. If we've got time afterwards, I've got a lot of opinions about antibiotic prescription duration, so I'm happy to share those with you, especially for those that might be anxious or interested in why there's a range. There's also been studies to look at dental antibiotic prophylaxis. A lot of this has been led by Dr. Katie Suda using this VA data set. Her research has found that a lot of the antibiotic prescription durations, at least among veterans, have been prolonged. So the median prescription duration was 7 days for antibiotic prophylaxis. Using kind of a narrower definition, she found that only about 15% of antibiotic prophylaxis prescriptions were appropriate, according to American Dental Association guidelines. She's actually looked at this longitudinally in a JAMA Network open paper and found that a substantial amount of dental antibiotic prophylaxis prescriptions have been unnecessary according to condition as well. There's been several people that have evaluated dentists' experience with guidelines. I think one of the important papers was by Peter Lockhart and Jada in 2020. He found that most dentists were comfortable with the 2007 American Heart Association and American Dental Association guidelines for the prevention of infective endocarditis, but felt a little less clear on the prosthetic joint infection guidelines. But there was still a fair amount of uncertainty about appropriate use for both guidelines, which he felt may have resulted in kind of a lack of concordance between dentists' beliefs and their practice behaviors that he called, quote unquote, a paradox in practice, where the dentist might feel comfortable with what the guidelines recommend, but then when people look at it afterwards, they see practices that deviate from those guidelines. And there's a number of factors involved, and they share similar issues with medicine too. Patient expectations, orthopedic surgeon demands, things like that are hard to take into account and challenging to balance. We see that in primary care settings and in dental settings as well. I think it's a major frustration for all healthcare providers. So putting that into balance is, and kind of the question is, why does this matter? Would a couple extra doses of amoxicillin or extra doses of clindamycin, does that actually do any patient harm? So that's the next question. And it probably does. So this is research from Martin Thornhill, who's based out of the United Kingdom, and he looked at a data set called the yellow card data set, where UK citizens report adverse events to the government using this standardized system. And he compared antibiotics prescribed by dentists. So you can see on the x-axis here are commonly prescribed antibiotics in dentistry. Interestingly, dentists in the UK prescribe a lot more metronidazole than in the US. So there are regional differences in antibiotic preferences. And then on the y-axis, you can see adverse events per million prescriptions. And the big one that stands out here is clindamycin. So you can see clindamycin causes a lot of non-serious events, but it also causes a lot of serious events. The biggest concern among these is C. diff too. So Clostridium or Clostridioides difficile infections are an infectious diarrhea that are associated with antibiotic exposures. And there's a lot of people that die related to C. diff infections, especially elderly patients. And you can see there, he did identify in this data set people that had fatal adverse events related to clindamycin. And these were largely driven by the C. diff diarrhea that we see. So in terms of dental antibiotics, overall, the oral antibiotics are relatively safe, but the main bad actor that we worry the most about is this clindamycin antibiotic that we typically prescribe for patients that are penicillin allergic, and why you've seen recently people kind of steering away towards recommending clindamycin as an antibiotic to be used in penicillin allergic patients. The other data about C. diff and dentistry in the U.S. comes from researchers based out of the Minnesota Department of Public Health. They're part of some CDC collaborations where they track and evaluate all episodes of C. diff infections that occur in several counties in Minnesota. And what they do is they get data on and each episode of C. diff, and then they investigate the patient and what antibiotic exposures were present. And they looked to see who was prescribing those antibiotics. And they surprisingly found that about 15% of C. diff infections were related to dental antibiotics in Minnesota in a 6-year period. And these typically were older patients. And again, these were patients that generally were prescribed clindamycin, which is kind of more ammunition to try to avoid clindamycin when possible. And it also demonstrates that there's potential real harm related to antibiotic prescribing, especially if it's unnecessary. There's also been lawsuits related to dental antibiotic prescribing too, and they can cut both ways. So if you overprescribe antibiotics, like this case, your patient might develop an episode of C. diff related to clindamycin, have an adverse event where they need to have surgery and have a lot of medical complications. And you'd be potentially liable if the patient sued you and the court found that antibiotic prescription that you gave was unnecessary. On the other end of the spectrum, and it's challenging, being stuck between a rock and a hard place, is if someone warrants an antibiotic prescription and then they weren't given one, then you also could potentially be liable related to adverse events that occurred related to not prescribing antibiotics. So my opinion and my experience related to medical legal aspects of malpractice would be that the best thing you can do, the easiest thing you can do is try to follow the guidelines as much as possible. The medical malpractice cases, usually what happens when the expert witnesses start looking at things is they pull up what the guidelines are, and that's the gold standard, and that's what you're supposed to do. So if you say, hey, the guidelines recommended I prescribe this antibiotic, sorry, the patient developed C. diff, but it was the right move based on evidence-based dentistry, that's case closed. That case isn't going to go anywhere. So I know it's challenging, but it's a fine line to walk between over and under prescribing antibiotics. But the absolute easiest thing to do is to just try to follow the guidelines as much as possible. The other thing that is still being explored is microbiome changes related to antibiotic use in dentistry. This audience probably knows all of this information, but antibiotics kill both good and bad bacteria. And this literature is still in its infancy, but there's lots of new literature that shows good bacteria play important roles in human and animal health. So we're learning that bacteria in your gut play an important role in immune function, and people with autoimmune disorders have associated disruptions in their gut microbiome. In animal studies, they found that antibiotic exposure and disrupted microbiomes have been associated with obesity, allergy. Disrupted microbiomes have been identified in cancer patients. And then there's other bacterial infections that we see with microbiome changes too, including other multi-drug resistant organisms as well. The CDC's been really passionate about kind of evaluating consequences for overprescribing antibiotics. It's hard to quantify some of these, as you can imagine. So they look at adverse drug events related to antibiotic use, and 1 in 5 adverse drug event emergency department visits, which is a hard statistic to wrap your head around. But these would be people that present to the emergency department with an adverse drug event. 1 in 5 is related to an antibiotic. And we know that antibiotic resistance also means that the antibiotics are less effective down the road. And we're starting to see that with a number of common conditions that we treat where we're having to use broader antibiotics instead. Fortunately, the trade-off when we use these broader antibiotics is they have more microbiome disruption. usually higher rates of side effects as well. So this causes patients to be at higher risk for more complications with antibiotics that we prescribe as well. The two figures here kind of provide data from the CDC about how many antibiotic-resistant infections are present on an annual basis and how many deaths are present too. So the CDC estimates about almost 3 million antibiotic-resistant infections occur yearly and about 36,000 deaths. You can see this C. diff is a major contributor for this. A lot of that is because C. diff is easier to measure than some of the other antibiotic-resistant infections. And we can see that antibiotics also increase the risk of patients developing infections related to antibiotic-resistant and drug-resistant organisms too. So there's been a number of existing antimicrobial stewardship techniques in healthcare. I'm going to touch on the hospital setting. So the CDC's released these core elements of hospital antibiotic stewardship programs. These have a lot more teeth because they've been followed by Joint Commission requirements that accredit. This is an accreditation body that accredits most hospitals. So you can see there's a long list of things that they need. So the hospitals need to have leadership commitment, some sort of accountability. So a pharmacist or physician leader, someone with expertise in this area. They need to develop some sort of intervention, track if their intervention is working or not, report that information to hospital leadership, and then educate people about antibiotic stewardship. In outpatient settings, we're still kind of in our infancy about doing antimicrobial stewardship interventions. A lot of that is because there's less motivation for people in outpatient settings to engage in antimicrobial stewardship. There's no joint commission that really oversees most outpatient settings. And honestly, it's hard to implement these. It costs time, it costs money sometimes, and it takes time for people as well. So the requirements are a lot smaller. Usually for outpatient settings, they would want some commitment, action for policy and practice, like an intervention of some sort, tracking and reporting, and then education and expertise, where we're providing education for people about outpatient antibiotic stewardship. In medical settings, that's translated usually to a few interventions. So this table kind of provides a broad overview of what interventions have been done for outpatient stewardship in medical settings. The first one is provider or patient education. So you can imagine that's one of the easiest things to do. That might be something like this, where there's a seminar or educational materials. It could be as simple as a pamphlet. Provider feedback, which we'll get into, where we potentially tell providers how they're prescribing antibiotics compared to their peers. Releasing guidelines, delayed prescribing, which I think is a really cool technique that we'll talk about. Communication skills training, restriction, which I don't think works in outpatient settings for several reasons. Decision support that we'll talk a little bit about. There's a new one since this came out with behavioral nudges, one's commitment posters that we'll talk about, financial incentives, and then a new category called diagnostic stewardship, which is based on laboratory testing. So we're going to go over these in a little bit more detail. Provider and or patient education is usually discussion of current guidelines. It can involve feedback. Like I mentioned, it usually has pamphlets, can be single to multiple sessions, and the data shows that there's kind of mixed results. It's probably the base and lowest level of outpatient antimicrobial stewardship interventions. Provider feedback is kind of where things have been trending recently. This is like an audit and feedback where we evaluate antibiotic prescribing trends. So we might ask a pediatrician or evaluate pediatricians to see how often they're prescribing antibiotics for viral upper respiratory tract infections, and then provide feedback to those pediatricians. So you can see it usually is measuring something against adherence to clinical practice guidelines. Benchmarking, which is comparing peer-to-peer percentage of residents who initiated an antibiotic might be an example, or percentage of antibiotics with a prolonged duration might be some of the reports that we would provide. This is an example that was done out of Canada in long-term care community settings, where they would send this out regularly to physicians. They'd say, most of these bacterial infections that you treat should only require 7 days or less of antibiotics. Click on this link to see how you're doing compared to your peers. Here's a PIN number. You can see that they also will track antibiotic prescribing reports too. So they'll see how often people are looking at this and might do feedback to say, hey, we haven't seen you log on to this recently. And there's two different flavors to this. One might be kind of an overall peer comparison, like maybe an anonymous result, like this is you compared to 20 of your practice partners. Sometimes it's also intentionally open, where you could see who the names are of your peers that are prescribing. So the good people can be highlighted, and the people that aren't doing great can as well. You can see there's pros and cons with this. It can also upset a lot of healthcare providers, as you can imagine, with people saying, hey, I didn't know you'd be digging into my data, or my patients are different than other people's. So it's by no means perfect, but it's an example of what's happening in some outpatient settings from a research standpoint. And overall, these have been effective at reducing antibiotic prescribing. But I would say there is a little bit of a cost that some people don't like these. Other people have even gone to an extreme where they will tell people that they're not a top prescriber. So they'll tell, if you're in the bottom 75%, you'll get a message like this that'll say that you weren't in the top 25%, trying to motivate them to improve their performance. I would say that's I think it's an interesting approach. It might be demoralizing for someone to get a monthly or quarterly report continuing to tell them that they're not doing a great job. But that's also an effective approach. The next one is guidelines. So there can be institutional or clinical practice guidelines, like American Dental Association guidelines. You can create your own guidelines or release guidelines that are modified. I provided an example from our hospital. So we have a set of guidelines that kind of extend outside of standard guidelines. So here are guidelines for someone that presented to the emergency department with a bite wound. You can see human, cat, or dog. Then there's recommendations for antibiotic prophylaxis, what the recommended therapy would be, and then alternative agents potentially too. There's pros and cons with these, you can imagine. The pro is we can modify things and update this. The con is that we don't have a good way to force someone to look at this too. So all of this is housed on a website that people don't like to log into at our institution. They find it somewhat cumbersome because we can't have them save their information, since a lot of healthcare providers are going from computer to computer. So even though this educational information is out there, they don't always see it, which can be frustrating too. One thing that I think could work well in dentistry is delayed prescribing. There's kind of two different approaches for this. So one is to give a prescription to a patient, tell them only to fill it if they feel better. A second approach is to tell a patient to call if they don't feel better, and then you write a prescription. In medical settings, this is commonly used for viral infections that may be bacterial if symptoms persist. So the vast majority of cases of sinusitis are viral. But if someone has sinusitis for an extended period of time, then the probability of it being bacterial increases. So in that setting, it may be appropriate to prescribe an antibiotic if someone still has persistent symptoms after a certain period of time. They've looked at this in Australia for acute respiratory tract infections, and they saw that the majority of patients didn't receive an antibiotic if they had a viral infection, About a quarter got an antibiotic prescription immediately, and then about 9% did this for delayed prescribing. And you can see the kind of common conditions they were doing this delayed prescribing for, which I think is an interesting overall approach, and may work for dental settings where you tell the patient, hey, it doesn't look like you've got an infection now, but if you start developing swelling or other red flags, fevers, I want you to call our office, and then we'll prescribe you an antibiotic. So I could see this delayed prescribing as being a approach that could translate to dentistry. The next one, which I think is really cool, is communication skills training. It's mostly done in pediatrics for viral upper respiratory tract infections. And as you can imagine, the pediatricians have a lot of pressure from parents who want their kid to get an antibiotic because they want their children to feel better. A lot of times they have to take time off of work. So I've learned a lot from this technique. I'm going to share kind of the summary video with you. I use it for this approach for all sorts of things. I'll use it for patients that want pain medications. I'll use this approach if I think that I might have a challenging discussion about antibiotics with patients too. So I want you to just view it with an open mind. It's about viral upper respiratory tract infections, but I think it can translate well to dentistry, including conditions where a patient may want an antibiotic and we don't think it's necessary, or a setting even with someone that may want a pain medication and they don't think it's necessary too. So I'm going to click on this link. I tested this before and it worked. We're going to give you the Cliff's Notes version of this. And I'm going to see if you can hear it. Actually, I'm not sure if you can hear it from this because the audio is going to be off. We're going to give it a shot anyway.
Now, let's put the 4 key communication practices together.
Are you able to hear it?
Treatment package. Here's what we recommend. Keep in mind that the treatment recommendation is one package comprising 4 key components. If a parent expects antibiotics and you determine that they are unnecessary, you should structure your treatment recommendation so that it includes the following components. Number 1, review your physical exam findings to make the case for your diagnosis. Number 2, deliver your diagnosis. Number 3, deliver your 2-part treatment recommendation, the negative treatment recommendation followed by a positive one that lists symptomatic treatments. Number 4, provide a contingency plan. After completing the physical examination, start your treatment recommendation by reviewing your physical exam findings.
Emily's chest is clear. I don't hear anything that sounds like pneumonia. That's good to hear. And her ears also look good. There's a little bit of redness in the back of her throat, but nothing too serious. It's probably from all of the drainage she's been having from her nose.
When you explicitly review these findings, it will signpost your arrival at the diagnosis. Doing so reduces the parent's expectations for antibiotics and the likelihood that they will question your treatment recommendation. Part 2, deliver your diagnosis.
So what she has is a really bad cold. It may be from some of the flu bugs we've been seeing lately. All right, that makes sense.
Part 3, deliver your treatment recommendation. We recommend that your negative treatment recommendation comes next. That way, you can end with your positive treatment recommendations. Lead into your recommendation in a way that shows you won't be done with just the negative remarks. Use the on the one hand, on the other hand, or use the there's bad news and good news. Part 3, deliver your treatment recommendation.
Bad news is that there's no good medicine that will treat this kind of illness. It's just not the kind of illness that an antibiotic will help. But the good news is that there is plenty we can do to make Emily feel better. She can have some herbal tea with honey and lemon a couple times a day to soothe her throat, and the honey will probably help her cough less. You can also give her an extra pill at night to help her nose drain, so that she can breathe a little more easily. And children's Motrin or Advil are really good for fever and some of the achiness kids can get with these bugs. Okay, you do have Advil at home. How often could she have it? If she's achy or has fever, I would give it to her every 6 to 8 hours. Otherwise, she doesn't need to be on any kind of schedule with it. once more as needed. Sounds good. And when can she go back to school?
Positive recommendations explicitly provide advice on what the parent can do to help with their child's symptoms. Listing symptomatic treatments is empowering for parents, but it is important to be specific in your recommendations, especially about over-the-counter medications. Parents can be frustrated by being told to use whatever your favorite cough medicine is. Specificity about medicines is reassuring and valuable. Part 4. Give a contingency plan.
As long as she has no fevers for 24 hours and is feeling up to it, she can go back to school. But if she doesn't seem to be getting better over the next 3 or 4 days, I want to hear back from you, okay? Okay. Now, I would expect that her nose should dry up and she should generally start to feel better over the next couple days. But I want you to call if she gets a high fever, 101 or higher, or if she starts having trouble with breathing too fast, or if she just generally isn't feeling better or she seems to be getting worse. If that happens, we might need to have another look.
Sounds good, Dr. Thomas. I just wanted to make sure something more serious wasn't going on.
There we go. All right. So I think that highlights, I think, really good communication skills training overall. I regularly use 2-part recommendations now when I talk with patients, and I regularly use contingency plans. And I'll tell you that it really helps dramatically in terms of framing conversations with patients, and it'll increase patient satisfaction. And interestingly, using approaches like this can actually shorten the amount of time you're talking with patients too, because a lot of times you without these techniques, you might be arguing with people about whether or not they need an opioid pain medication or they need an antibiotic, and using these types of approaches kind of disarms those patients before they can start arguing with you too. So I think it's a really cool technique. It's underappreciated in my mind. It's something I'd like to explore more in dentistry in the future. The last few we're going to go through quickly is commitment posters. So there's a group that put these posters up, a very low-tech intervention, saying that they made a commitment to responsible antibiotic prescribing, and they wouldn't prescribe antibiotics for patients with viral infections. The key to it is that it seems to work is that the healthcare provider puts their face on it and then they sign it too. So this has been up to a 20% reduction in antibiotic use. And these are, again, kind of these behavioral nudges that if these are in the waiting rooms, the healthcare providers don't want to potentially go back on their word when the patients see this already. And it kind of disarms the patients in terms of expecting antibiotics if they see a poster like this in a waiting area. Clinical decision support is another one that I'm actually very interested in researching. The very complicated table over here is how we prescribe antibiotics in the hospital. So this is vancomycin antibiotic, and you can see it lists things like what their creatinine clearance is. It has information about when they last got vancomycin, what the levels were for their vancomycin troughs, and then recommendations that you can provide dosing too. So it can give you milligram per kilogram dosing or straight dosing too, and you can adjust the antibiotics based on recorded ideal or adjusted body weight too. And this really helps making antibiotic prescribing easier. I should say, this seems like a lot of information. There's also little nudges in here to make sure that you're doing it the right way. So, the correct one, like recorded body weight, is already highlighted so that you don't have to make decisions about, I'm not sure which body weight I should be using. And then there's decision calculators too. So the one on the right here is one that people have used for a long time for strep pharyngitis, called Centaur criteria, the Centaur score, where you plug in information like the patient's age, what symptoms they have, like if they've got exudate on their tonsils, and it gives you a result about likelihood of the patient having strep pharyngitis and provides recommendations on what to do next. Diagnostic stewardship's less relevant for dentistry, but a lot of times in medicine, we use it to try to improve test performance, like reducing contamination in blood or urine cultures and assisting with the diagnosis of viral infections. certain tests like procalcitonin can help us differentiate between viral and bacterial infections. Oftentimes this is paired with an interpretation from the lab. So dental antimicrobial stewardship interventions have been fairly limited in the literature. There's an example from Alan Gross and Katie Suda that was published in the infectious disease literature. They followed the CDC outpatient stewardship recommendations. So they first did a needs assessment and literature review, provided education to providers, patients, and then developed a clinical guideline along with an algorithm. And then they measured antibiotic use before and after an intervention. This was in an urgent care dental clinic at the University of Illinois at Chicago. And they noticed a 73% reduction in antibiotic prescribing. And this was really simple and effective. So this was the algorithm that they had, and they just posted it up in operatories. So it may be a little hard to see. So I'm going to say is swelling present? Yes, no. Where's the location of the swelling? And then there's recommendations about considering antibiotics or no antibiotics. And then they've got recommendations of what antibiotics should be prescribed and the duration that's there too. So fairly low tech intervention, but really impressive results. The other examples where antimicrobial stewardship interventions have been done in dentistry is audit and feedback, like we talked about. So this is earlier on. So this is a group that did an intervention in England at 175 dental practices. They had a 6-week baseline period, then they did this feedback, and then a 6-week follow-up period. And they saw a 43% reduction in the number of antibiotics prescribed. Majority of them were related to therapeutic reasons in the UK. And they saw a change in antibiotic regimens and reduced number of non-guideline adherent antibiotics. And it looks like Dr. Van Kagen has a question here. Do you provide written materials too that repeats what you have said? Yes, I'm happy to provide written materials about this. In terms of my practice with patients, when we provide guidance and contingency plans, we can provide written recommendations as an after visit summary. So when the patient leaves our clinic, there's a summary that we can type up and provide them guidance of what they should watch out for, what medication they should pick up, things like that, which I think is very helpful because a lot of patients aren't paying attention.
Yes.
Or they have a hard time remembering what you said
Yes.
in the moment. We see that a lot with patients that have important things that that we might be relaying to them. So in medicine, it might be someone that is learning about if their cancer has recurred. In dentistry, it might be that they might need a root canal or that their tooth might need to be extracted. A lot of times with big news like that, their brain kind of shuts off and they're perseverating on that important thing, and they're not thinking about anything else you said after that. So the written materials can absolutely be helpful afterwards. I think that's a great question. Yeah, we've got another comment here too. In general, antibiotic use in dentistry for oral infections is adjunctive therapy. Yeah, that's right. When definitive dental treatment's not available or to recover. I completely agree. What are my thoughts about antibiotic dosing and duration guidelines in dentistry? Should this be different from medical provider prescribing practices? That is a great question. I'll answer the first part about my thoughts about antibiotic dosing and duration guidelines in dentistry. I was on the 2019 guidelines panel, and there was a lot of anxiety, I would say, about the antibiotic range, the 3 to 7 days. As an infectious disease doctor, I have felt increasingly comfortable with ambiguity. So a lot of times from the guidelines, we have to review the literature. And as you can imagine, some of the literature will have a paper where they prescribe the antibiotic for 5 days only, or 6 days, 7 days potentially. And we see the same thing from medical trials too, where there might be a randomized controlled trial where we say, hey, this antibiotic, worked well, but we're kind of married a lot of times to the antibiotic treatment duration that was recommended in the randomized controlled trial. And a lot of those randomized controlled trials have not, there's very little interest in them changing over time. So for whatever reason, funding agencies have not been interested in funding a trial to say, is amoxicillin for 5 days as good as 7? Or can we compare 3 days to 5 days? Those studies don't exist yet. I'd love to fund them and I'd love to be part of them. I'm not in charge of those funding decisions. So that's why there's some ambiguity there. I'll say compared to medical guidelines, they'll say the same thing. It's sometimes they'll phrase it slightly differently where they'll say, usually a 5-day treatment duration seems to be sufficient to treat this infection, although you can extend the antibiotic duration if the patient still has persistent, symptoms at the end of therapy. So some people have been pushing to change duration based on the symptoms instead of based on a fixed duration, because we know everyone's different. Certainly the amount or the success rate for definitive dental treatment might be different. We see that occasionally for orthopedic surgery related infections where someone has a retained bone that might be infected, or they might have been able to scrape out a lot of the residual infected bone and they think it's down to healthy tissue. So a lot of times we're having those discussions about how long to treat based on conversations with the surgeons. But right now in medicine, I'll tell you, we probably overprescribe antibiotic treatment durations. And the trend probably over the last, I would say 5 years or so, has been evaluating if shorter treatment durations work as well as longer ones. And for the most part, the available data that we have shows that short durations work okay. And I'll also say, I have a slide on this, but I'm not sharing it. A lot of our antibiotic treatment durations are based entirely off of, the fact that, in ancient Rome, they decided that a week was 7 days. So a lot of our treatment durations are a week based on that, which seems somewhat absurd when you think about, modern evidence-based practice now too. And then should it be different from medical provider prescribing practices? I believe that dentists are far more knowledgeable about dentistry than medical providers. So I think that I know that medical consults are commonly done. And a lot of times the orthopedic surgeons or cardiologists will have strong opinions that are oftentimes not evidence-based, saying that the patient should continue to receive antibiotic prophylaxis. I'll tell you that I think a lot of them don't know the guidelines as well as you do. So you should feel empowered to follow what you think are the guidelines and what you think is best for the patient. And a lot of medical providers prescribe antibiotics that are too broad for dental infections, in my opinion, and probably prescribe durations that are longer than necessary too. So, and that's related to their anxiety and lack of, experience treating dental infections. I hope that answers your question. I'm going to go through the next slides pretty quickly here too. This one, they did this audit and feedback approach too that I mentioned, and they just kind of broke it up into different individual segments to see what worked best. They did audit and feedback, written behavior change message, and then they did benchmarking compared to local peers. Health board comparator is the region. So it'd be like their county in Scotland where this was performed. And they saw a reduction in antibiotic prescribing for most of their interventions as well. And then in Australia, they've created clinical decision support tools where they've reduced antibiotic prescribing too. So they created a website called Drugs for Dent, where you can see they had a specific clinical scenario and a drop-down menu. So the example here is irreversible pulpitis. They provided an explanation that dentists could relay to patients, and then a dentist's explanation too. And this information could be sent to patients as well. They had this for pulp necrosis you can see there with acute apical periodontitis too, and other common dental conditions. This was actually viewed very favorably from the dentists that participated in it. They really liked that it had a ability. It also had information about individual drugs too. So the dentists liked that a lot. The person who built this is a dentist and pharmacist. So she was very keen on providing information to dentists about individual medications. So it'd have information about the direct acting oral anticoagulants and things like that too. This is the project that I've been working on. So this is creating clinical decision support tools for dentists that we're pilot testing at UIC. So these are just snapshots where someone would select an indication, and then they go through an algorithm where they'd say yes, no question. There'd be a series of yes, no questions, and it would provide recommendations if an antibiotic is indicated or not, and then incorporate some of the feedback with communication skills training that doctors can provide to patients, saying, providing a rationale for not prescribing antibiotics. So the quotes there say, for your condition, the experts state that the risk of antibiotic side effects outweigh the benefits of preventing an infection. And then it has a second part recommendation, providing a contingency plan in case the patient does not feel better. So it says, if you develop a fever, worsening pain, swelling, or trouble breathing, or you're not feeling better over the next couple of days, I want you to call our office. And that's based on the work from Dr. Rita Mangione-Smith that we shared before. It also has dosing assistance in it too. So if an antibiotic is indicated, it has the recommended antibiotic all laid out. So the dose, the number of tabs to dispense, and refills as like a mock antibiotic prescription, as well as alternative options. And then pediatric weight-based dosing is present too. So in terms of dental antibiotic stewardship, future interventions, based on the information from medical literature, I think clinical decision support is probably the most promising. I think communication skills training would really be cool too for, I think helping with expectation with opioids and pain as well. I would be intrigued about commitment posters, although I don't know if it would work as well, because patients go in just knowing they have dental pain. So they might not know what condition they have. And then delayed prescribing, I think, is promising too. So I'd like to acknowledge a lot of my research collaborators, and then my funding agencies as well. And then I'm happy to answer any questions too. And then if we've got a couple extra minutes, I have some hidden slides about antibiotics if you want an infectious disease opinion about doxycycline and Keflex and some of these antibiotics that you prescribe less often too. I'm happy to share that as well. And it looks like I've got one question here too about referral to specialists. Yeah, can be delayed. Yeah, there's a short course of antibiotic prescription with 2-week intervals, something that can be considered. I think that's a great question. We deal with this sometimes in medicine too, when we have a patient that's got like an infected joint or infected hardware, and the surgery may take a time. Usually if the patient's been stable and there's ironically, if the infection is draining, like they've got a fistula or sinus tract, usually those patients do okay if they're not on an antibiotic for a prolonged period of time. But if you think that the patient needs definitive care and their tooth is going to swell up, or they're going to develop a systemic infection related to this, and they can't get definitive care, in our clinic, sometimes we'll give patients antibiotics to kind of, quote unquote, cool them off until they can get, definitive surgery for it. So I would say that it's kind of a case by case basis. I would hope that you wouldn't have to wait months for someone to get their care. But for a short period of time, I think, preventing the infection from spreading with antibiotics can be an approach that works too. So, yeah, that's a great question.
Okay, we do have a few more minutes for questions if people want to put them in the Q&A box. Dr. Durkin, this was a fantastic presentation. A lot of nuances when we're thinking about prescribing or not prescribing.
Yeah, absolutely.
And that decision tool, that the clinic decision tool that you're developing is going to be, I think, very helpful and beneficial to frontline providers.
Yeah, that's my goal, is to try to make it easier to follow the guidelines, both from a patient safety perspective and a medical legal perspective. Because I think you could write, hey, I followed this tool and it's based on guidelines. So, yeah.
Is antibiotic prescription still indicated for people with very low neutrophil cell counts, 500 or less? I know that used to be the case.
That is a great question. I don't recall. I'd have to pull up the guidelines. I think that immunosuppressed patients, if they have a low absolute neutrophil count, like under 500 or 1,000, and you think that you're going to be manipulating their gingival mucosa, I probably would give them antibiotic prophylaxis. Yeah, in that setting. I would confirm with the guidelines, but I think that in that setting, I think that makes sense.
Okay. I think we've got some questions coming in or comments. Go ahead. From Charles Rim, I agree, Dr. Durkin, about it is case by case. My clinical practice is only when clinically indicated and need to clearly communicate with patient about the recurrence of infection. We did pull together an antibiotic stewardship for dental providers, which we shared with a number of dentists that were practicing in Illinois counties where they were prescribing at a higher level than other counties. And so we shared, and I just put this link in there. It has some of the commitment posters and things like that you talked about, Dr. Durkin.
Yeah, this is fantastic. I think it looks really great, and I think it looks very similar to the CDC guidance too. So it's got the CDC logo at the bottom too. So that's fantastic. Yeah. The patient education, I think, is valuable. Staff education, and then I think all of this is great. I think having it in a format that's easy to follow, I think makes a lot of sense. To sometimes having information dedicated to patients when they leave, I think would be helpful as well. So I don't see that as much in terms of what's been prescribed in dental settings, and honestly in medical settings. I don't know if there's a standardized material that we've normally done other than writing in the after visit summary, free texting information, but there probably should be a more standardized approach too. That's a great fact sheet. I'm glad to see. I'm probably preaching to the choir with all of these, with all the people that are attending here, but it seems like Dr. Rim's already doing a lot of the right things with his practice too. I think that's fantastic.
Yes. So let's see. So we're at time. I guess people have left maybe even, but I want to, if you haven't left, I want to invite you to the last of the oral health session. There's a 15-minute break, and then we're going to have a session on the management of acute oral infections in the medical setting. So additional information I'm probably adding on to what we've already heard for the oral health practitioner. So I welcome you to join us for that session. And I want to thank you, Dr. Durkin, for that very excellent presentation and all the materials and resources and concepts that you shared today. Thank you.
Thank you for having me.
Mhm.
Bye.
Bye.